All right. Good afternoon, everyone. Welcome to the final presentation of the National Forum of COVID-19 Vaccine. My name is Nina Morano. I'm the team lead for the Globally Mobile Populations team within the CDC COVID-19 response. We're very happy to present a workshop for you this afternoon regarding outreach to refugees, immigrants, and migrants. We'll call them RIM populations, about COVID vaccine. We have an exciting group of speakers who will describe their overarching projects and then focus on how outreach to RIM populations translates at a local level. We think of this as a boots on the ground forum, giving real world examples and resources for you to use during the response. Throughout the presentations, please send your questions to the chat box and we'll respond and hold a discussion after all three speakers have presented. Next slide. We have three presentations for you today. First, we'll have a presentation on the National Resource Center for Refugees, Immigrants, and Migrants. We call that NARC-RIM, with the co-PIs, Bill Stauffer and Erin Mann. They will discuss this resource center and guidance, health communications, health education, online training, and technical assistance that is offered through this center. Our second presentation will be by Emily Gentes and Christy Canuti Rodriguez and the Centers of Excellence in Newcomers Health. They will discuss culturally responsive navigation for refugee and immigrant COVID-19 vaccine access and delivery at a clinic in Denver. And then finally, our third presentation will be from Alfonso Rodriguez-Lanes and Sylvia Partida of the National Center for Farm Worker Health, discussing vaccination outreach for farm workers. Next slide. So who are refugees, immigrants, and migrants, and why are these groups so important for vaccine planning? Well, there are many legal and informal definitions of refugees, immigrants, and migrants, but the commonality among these populations is that they're non-US born or foreign born persons, and they are highly diverse culturally and linguistically. In addition to the almost 45 million RIM persons living in the US each year, tens of thousands of refugees and hundreds of thousands of immigrants and migrants come to the US seeking to begin new lives. RIM populations form a substantial portion of racial and ethnic minorities and the US essential workforce, particularly in the healthcare, agriculture, food processing, and retail industries, and thus are at high risk for exposure to COVID-19. So these groups, what kind of barriers do these groups face, and what type of things do we have to consider to try to overcome those barriers? I'm just going to list a few. There are many, but when it comes to vaccine, we need to overcome things like RIM populations not knowing that they have a right to access the vaccine, that they may be a priority population for the vaccine, and that it's free, and where they should go to get the vaccine. They also have probably a dearth of information that is culturally appropriate in the correct languages and in the media formats that they prefer to access at both vaccination sites and as well as all the information that's provided through the web and social media. This also can include lack of access to interpreters at vaccination sites. Some may believe that sharing of personal data at vaccine sites, including the requirement for showing ID or proof of residence, will be used to track them down or be reported to federal authorities. Many are fearful of public charge, that accessing vaccine could affect their future immigration status for them or their family members. Even if they are legal permanent residents, because laws change, they may fear that their status may change as a result of accessing these vital services. Their belief systems, their distrust of vaccine and distrust of authorities who are providing it. Some may also have different knowledge and attitudes about safety of the vaccine as compared to the general population. For workers, lack of sick leave, whether that's a real or perceived issue, the fact remains that they're afraid of missing work to be tested for COVID-19 or to be vaccinated for COVID. Or if they are vaccinated, that they will likely miss work with no wages due to the potential side effects of the vaccine. Those are just a few of the many barriers that we must work collectively to overcome. So our four presenters today are going to be very pleased to give you some really, really good advice. I know that many of you have a lot of experience on the ground with these populations. We seek to learn from you and hope that you'll provide us with good feedback through the chat and through our discussion at the end of these presentations. So now I'd like to introduce our first presenters. Next slide. As I said earlier, it's Dr. Bill Stauffer and Erin Mann from the University of Minnesota, and they're going to be talking to you today about the National Resource Center for Refugees, Immigrants, and Migrants. Bill?
Thank you, Nina. And thank you to the CDC for inviting us to this very important forum. It's a very timely and important topic. Next slide. So I'm going to talk, as Nina said, about the National Resource Center for Refugees, Immigrants, and Migrants. I'll refer to it as the NRC for the rest of the talk. The NRC was a CDC-funded project that is meant to address prevention, contact tracing, and mitigation for COVID during the pandemic. Our major audience is really state and local health departments who for assisting them in working with refugees, immigrants, and migrants. We were born on October 1st of this year, so we're about 6 months old. We're ahead of our milestones. We're crawling, and I think we can pull ourselves up independently, but we're not quite walking or running yet. But we'll hope to share some of our resources with you here. Next slide. So we have we're housed at the University of Minnesota. We have many collaborators across many different institutions. We have some main organizational partners, and our organizational partners are the International Rescue Committee, the Migrant Clinician Network, Minnesota Department of Health, and the National Association of County and City Health Officials. And we're presenting the work on behalf of our group, but the work that's gone into this has been from our many talented partners and collaborators. Next slide. So our key activities are to collect, curate, when we find gaps, to create, and then also to pilot, evaluate, and disseminate best and promising practices, health communications material, health education, online training, and we hope to increase our technical assistance. We've begun some technical assistance and hope to increase that with time. Next slide. We are part of our governance body is a community leadership board, which consists of 13 community leaders from across the country. Really amazing people who inform us, help us make our decisions and priorities, review our materials, and offer other guidance. Next slide. This is our website, so hopefully we can attract a few of you here. It's nrcrim.umn.edu. Next slide. This is our landing page, and we know that the conference is about vaccines, but first we're going to take you for a little bit of a tour. So next slide. So our activities are quite broad, and we kind of lumped them into these categories, which is up to date. We have up to date events, activities, news, and literature. We also have health education and resources, toolkits, training materials, and vaccines. And so I'm going to go through these just very quickly. So next slide. So if you look at our website or you sign up for our newsletter, going backward. So if you look at our website or receive our newsletter, we have updated events, activities, and news, and we also keep an eye on the medical literature and post stories and literature that are pertinent. Next slide. We also have health education and resources. So this is one example. We have a translated materials library. It's got about over 4,200 materials in 175 languages. And you can go on the site and search by language, topic, or resource type. So resource type might be you're looking for a video, or you're looking for a poster, or you're looking for a checklist. And so you can search this library. and hopefully find some relevant materials. Next slide. We also create materials. And so when we see gaps, we create materials. And so you can find some of our materials on the website. Next slide. And when we have toolkits, and so we have 5 areas of toolkits right now: community engagement, communications, case investigation and contact tracing, partnerships, and testing. Next slide. So what is a toolkit? It's a collection of guides and checklists, promising practices, educational material, and we put additional resources as well. Next slide. So I'm just going to go very quickly through the community engagement checklist or toolkit. So this would be an example of the guides and checklists. We have a total of 5 within this toolkit. I'll just point out the bottom one just as an example is supporting and creating, co-creating meaningful community advisory boards. So many people have been hearing on the conference about community advisory boards and involving communities. And so what we hope to do is like develop guides and assisting tools to help you create these, especially if you don't have experience. So this kind of walks you through how to get a representative community, how to lay down ground rules, and all those sorts of things. Next slide. These are some more of the guides and checklists. Next slide. Then we also have promising practices. And again, through the conference, and many of you know what promising practices are, we've got about 12 different promising practices in the community engagement, and they can be anything from community night, some things that even if you have a lot of experience might give you some ideas, to how to involve community liaisons or listening sessions. Next slide. Or involving or thinking about partnerships with key partners like state refugee coordinators or in the community faith-based organizations. Next slide. And then there we have some resources in addition. And we try not to have a laundry list of resources. We try to pick important resources that are helpful. Next slide. And then finally, we have on-demand training. And so, I mean, just using contact tracers as an example. So we try to supplement existing materials. We try not to duplicate. So there's several really good contact tracing courses. And what we try to do is supplement those courses. So in those courses, there's very little on working with RIM populations. And so we've created supplementary materials around language, around using interpreters, things like cultural humility, social determinants that are meant to complement those. And in addition, we, in our conversations with contact tracers, found a very large level of stress. It's a very difficult job. And so we've also created online materials for stress and resilience and contact tracers and case investigators, along with a supervisor guide for helping their contact tracer and case investigators. Next slide. So with that, I'm going to turn it over to my colleague and friend, Erin Mann, who's going to talk a little bit more in depth about a couple of our resources. So Erin.
Thanks so much, Bill. Yeah, as Bill said, I'm going to take us through a couple of activities that we're doing here at NRC RIM specific to COVID-19 vaccine community outreach. So I wanted to kick things off with this concept of the vaccine journey, and some of what Dr. Morano said in her introduction was a really nice summary of some of the things that you see here on this slide. So this was a concept that we developed with our partners through a brainstorming session, thinking about as an individual goes from start to finish with getting a COVID-19 vaccine, just thinking about some of the factors, the barriers, the opportunities to make sure that the vaccines happen. And we've been using this as a bit of a North Star to help guide our activities, and whether it's promising practices or other resources, trying to align those specifically with things here on this vaccine journey. So thinking really at a high level with the components related to choice, access, and experience. And we know that the experience is particularly important with COVID-19 vaccines because folks will need to go back and do this all over again with a second dose. So speaking to the point about vaccine choice and vaccine messaging, that first step in the vaccine journey, I wanted to share a little bit about some work we're doing related to community-led messaging. So we're partnering with IDEO.org. They're a nonprofit design studio that takes a human-centered design approach when developing health messages. So our goals in this partnership are twofold, first of which is to co-create messaging directly with communities, and then also develop some templates, guides, and really user-friendly materials so others can take that approach, take those resources, and build some messaging with their communities. And I'll talk in a couple of slides about the work we're doing around vaccines, but it builds upon some initial work we did with CICT with IDEO.org. So we were really grateful to work with some fantastic community members through this work for both the CICT and the vaccine messaging. We've been working with a primarily Spanish-speaking farm worker community in Florida. We're lucky to work with the Congolese community in Texas for the CICT. We were lined up to work with them again in vaccine. We've been partnering with the Hmong community in Minnesota for the CICT, and then a new partnership with the Haitian community in Maryland around vaccine. And we'll be expanding to additional communities over the next several weeks. So some of these key findings around messaging at a high level, and I know that this is information that a lot of you on the line are well-versed and well familiar with this, but the IDEO.org process really brought a lot of this to light. So the importance of clear, simple, direct language. We tested a couple of different options for the tone of messages, whether it was humor or messages that might instill a little bit of fear or worry or positivity. And we definitely heard that positivity was the way to go. We also heard some really interesting information about the use of idioms and proverbs. We know that we should all avoid translating English idioms to other languages because it just generally doesn't work. But we heard that using idioms and proverbs that are familiar in the target language can be a really effective way to have messages resonate with communities. And then also making sure we strike that balance between messaging that's really scientific, but also humanistic. A couple of other key findings, again, things that folks on the phone probably are familiar with, but we experimented with using photography versus drawings versus cartoons. And we heard loud and clear that the messaging is most powerful if folks see real people. And if they see photography that resembles their community and they can see their community in the images that we use. We also got a lot of helpful feedback, just catching that in the images, we should make sure that we're depicting people who are following COVID-19 safety guidelines. So we had a lot of beautiful community photos, but we had to stick with ones where folks are wearing masks, particularly for the contact tracing messaging. So just to give a quick overview of some of the contact tracing work, which ultimately is informing some of our vaccine work, here's an example of one of the posters that we co-created with the Congolese community. This is a message in Swahili about contact tracing, protecting our community and allowing us to know who else might need to get tested so we can stop the spread. So this emphasizes the positive aspect, the community piece, and really distills the message around why contact tracing is important. A couple of other quick examples from the contact tracing work. We learned a lot about messaging centering an act of love. So whether it's notifying others or disclosing symptoms and framing that as an act of love. We also noticed that the messaging around answer the phone, answer the call, pick up the phone could be a little bit threatening, and instead focusing on saving this number. So giving people the phone number that they might receive a call from was a better angle to take than encouraging folks to always answer the phone. The other output of the contact tracing work that will also inform the vaccine work is a guidebook. So it's kind of a choose your own adventure sticker book. It was designed for contact tracing, but there's a lot of really helpful exercises and learnings in that guidebook that will apply to vaccines as well. So we have this on our website as a PDF. We also have it as a web page you can click through. We have a video that accompanies it. And then there's also a set of Google Slides and an image bank. So anybody who wants to create some of their own messages, you don't need any design software. You can add your own logos. So we're hoping this will be a resource that a lot of folks take advantage of. So to give you all a little preview of the vaccine messaging, I'm excited to share this today. It's the first group outside of our working group that's seen some of these initial messages. So here's a series of messages that we developed with the Haitian community. So in Haitian Creole, focusing on vaccination is blank. And what we heard is vaccination is love, it's hope, it's strength. We also heard that the community really liked to see the colors of their flag represented. So we styled this after the CDC vaccine stickers and included the colors of the Haitian flag. You can see that right above the main message. Similar sort of message was developed with our community of Spanish-speaking farm workers in Florida. The first message is a little bit different. Rather than vaccination is love, we heard that vaccination is protection is a more powerful message. Again, following the color scheme, these folks were from Mexico, so they were excited to see the colors of the Mexican flag depicted on the messaging as well. So our next steps with the vaccine messaging, we're going to be doing some ongoing testing of these draft materials. And by testing, I mean we're going to get these out to communities and they're going to give us feedback on what they think. We're going to build out the assets, so it'll be more than just the examples you saw. There'll be some additional social media, PSAs, other materials. We're going to continue to build out our guides and templates so that others can use this as a resource. And then, as I mentioned, we're really excited to expand this to some additional communities. I'd like to also share that in addition to this very community, hyper-local approach, which we think is really the ideal way to do this, we're also putting together a supplement of broader communications assets that we're going to get translated into a lot of different languages. And we're going to build those so health departments and others can add their own logos. So some additional fact sheets, some PSAs, social media, trying to make these resources as user-friendly as possible. And then just to very briefly elaborate on what Bill said around the promising practices, we're really excited that we've been able to learn so much from the experts in the field. And we've been collecting a lot of promising practices through one-on-one interviews with public health professionals, health systems, community leaders. We've done listening sessions, many thanks to groups like Switchboard and the Association of State Refugee Health Coordinators who've been really generous with their time. We hear from our partner organizations, other means of getting these promising practices. And the goal is really to get these out to folks who might be interested in what others are trying. So we release new promising practices pretty much on a weekly basis on our website. And I know folks who've been listening to the forum the last couple of days have probably heard similar things, but we've heard some exciting examples. For example, the state of Washington has some really cool work happening with community vaccine listening sessions. Here in Minnesota, we have some exciting partnerships with faith-based organizations. We've been hearing about people repurposing their mobile vaccine activities that were originally used for influenza and childhood vaccines to now deliver COVID-19 vaccines. And then through our community leadership board, we learned about some work that's happening with pop-up clinics at apartment buildings and partnerships with community pharmacies. So lots of exciting stuff, and we're always humbled and grateful to hear what those in the field are learning and help to share that with others. And the last resource I wanted to mention, in addition to the promising practices, sometimes what we hear in interviews can't be summarized in a promising practice. Maybe it's something higher level or a specific tip. So we've been putting together a series of checklists about vaccines, testing, and contact tracing specific to refugees, immigrants, and migrants. So this is just a little preview of a particular checklist. So trying to put together resources in a really user-friendly way. So with that, thanks so much for listening. Again, we hope that all of these resources will be helpful to those on the line. We're really here for you and want you to check out our stuff and tell us what you think. So with that, I will turn it over to Emily to take us to the next presentation.
Thank you so much, Erin. And thank you to the organizers of this forum, the CDC forum, as well as this forum, for the opportunity to present some of the projects that we have in the Centers of Excellence in Newcomer Health. Next slide, please. So the Centers of Excellence in Newcomer Health really focuses on newcomers in the initial resettlement period, and this is up to the first year after arrival into the United States. As many folks know, the number of newcomers and refugees has really varied since the program's inception at the Refugee Act of 1980. And you can see at the right-hand side that the Biden administration has proposed 62,500 potentially. This is all under discussion for 2021, and then up to 125,000 for 2022. So we'll be watching those numbers and that information as it is determined under the presidential determination as we go forward. Next slide, please. So who are newcomers? So the newcomers in the U.S. Refugee Admissions Program include refugees as well as SIVs, who are special immigrant visa holders. Those are our translators from Iraq and Afghanistan who now face security concerns for their participation and work with the U.S. government. Also victims of human trafficking and asylees, as few as a couple other smaller groups. Next slide, please. In 2015, we established the Centers of Excellence in Refugee Health to improve the health of refugees resettling in that initial resettlement period by providing data and surveillance activities as well as guidelines for a domestic medical screening exam. And those that domestic medical screening exam usually occurs within 30 to 90 days after arrival. And sometimes that exam can happen in different settings, but it's more and more happening in medical homes, which Dr. Rodriguez, Canuti Rodriguez is going to discuss in our next presentation. But really the Centers of Excellence established being able to look at some data to understand the primary health concerns of newly arrived refugees and newcomers, as well as trying to understand how we can better inform some of the domestic medical screening exams. Next slide, please. So this last fall, we established the advancement for the Centers of Excellence in Newcomer Health by having some of those same pillars where we look at data and surveillance, but also communications and guidance and how we talk with both the newly arrived newcomers, but also the clinicians that see them. So whereas the NRC RIM really focuses on reaching state and local health departments, the Centers of Excellence in Newcomer Health really works towards reaching clinicians and the newcomers indirectly through those clinicians. And how can we better message to the clinicians to help and support our newcomers? We also have health education goals with this new cooperative agreement, and also clinician training on some of the guidance documents that we've developed, and as well as some best practices on how to work with newcomers, as well as set up some of the refugee health clinics that help get our newcomers off on the right foot. Next slide, please. So in the COVID response, our centers are working towards some special COVID analyses, looking at how COVID is affecting our newly arrived refugee populations. Also looking at, we're hoping to be able to look at vaccination within our refugee or newcomer populations to understand where we may have areas where we can have growth and try to increase vaccination during these areas. And so ways to increase vaccine confidence based on some of the information we already have about existing vaccination rates. Next slide, please. Another one of our activities from our Centers of Excellence partners is the use of cultural and patient navigators to help with contact tracing. And so some of our screening clinics have been using patient and cultural navigators for quite some time to help improve outreach, communications, health education to our newly arrived newcomers. And so this is using these folks and these resources and ways for COVID contact tracing seems like a natural fit. And this is part of the reason that I think we wanted to have Dr. Canuti Rodriguez speak today, is how using these type of navigators has improved outreach to some of the communities that we're so desperately trying to reach. So with that, I'm going to turn it over to Dr. Canuti Rodriguez, who is an assistant professor of pediatrics at Denver Health Pediatric Emergency Department and the University of Colorado School of Medicine. And she's built and oversees the Denver Health non-English, non-Spanish navigation program, which provides culturally and linguistically responsive navigation to those who do not speak English or Spanish and refugee patients. So with that, I will turn it over to Dr. Canuti Rodriguez.
Thank you so much for having me, and thank you for having this panel and topic. So as was mentioned, I work at Denver Health. So I'm a pediatrician in the Denver Health Pediatric Emergency Department, and then also run Denver Health's non-English, non-Spanish navigation program. And so I'm going to be talking about our culturally responsive NENS, which is non-English, non-Spanish, I like the acronym NENS, navigation program, how we built it, what we were doing before the COVID-19 pandemic, and then how our work has shifted related to the pandemic and now to helping with COVID-19 vaccination for refugees and immigrants. Next slide, please. And I have no disclosures or anything. Next slide. So why culturally responsive NENS navigation? So the idea for our program came from immigrant and refugee community members. Early in my career, I was exploring barriers to healthcare and strategies for improving access for refugee and immigrant populations. And part of that involved focus groups with African immigrant and refugee community members and leaders. What has now become our NENS navigation program is the result of suggested strategies from that work. And these are a few illustrative quotes from that early work. So the first is, we trust our people more than other communities, more than other persons. I can explain my problems fully to the person who speaks my language, and I know that he belongs to me. And another quote was, if they have a Somali person working there as a healthcare provider or a nurse or a translator, it will help a lot to facilitate understanding between the doctors and the clients and the Somali moms and fathers. So taking that feedback and other feedback into account, over the last 5 years, and we've built what is now the Denver Health NENS navigation program. So next slide, please. There we go. And so this program's been built through a series of grant-funded patient care initiatives. It remains grant-funded, though we're working on that. And I want to, before I get into our program, briefly explain Denver Health, the location of our program, because it understands our outreach. It helps for people to understand our outreach efforts, to understand the location a bit. So Denver Health is a large integrated community health system in Denver, Colorado. As a safety net system, Denver Health serves the majority of Denver's publicly insured and uninsured patients, and also serves a large immigrant and refugee populations. There are more than 90 languages spoken by our patients in the Denver Health system. In addition to the main campus that has a large hospital and a myriad of specialty and preventive care services, Denver Health also has several community health centers that are scattered throughout Denver and that have internal medicine, family medicine, pediatrics, dental services, integrated behavioral health, and then also OBGYN services. And they serve as medical homes for Denver Health patients throughout the city of Denver. Our refugee and NENS patients are seen throughout the Denver Health system, but the majority of these patients live near and have a medical home at one of our clinics in Eastern Denver. It's called the Lowry Family Health Center. And Lowry also houses the Denver Health Refugee Clinic, which, as Emily was mentioning, provides domestic medical screening exams for newly arrived refugees. So that's housed within one of the medical homes at Denver Health. In addition, there are large Vietnamese and Somali Bantu populations on the west side of Denver who are seen at a few of the family health centers on that side of town within our system. So, and I mention this because as we built our program, it was important to know where specific NENS and refugee populations live within Denver when we were considering which navigator would be based at which clinic and which clinics would have navigators at them. So even though they work system-wide, they're based at one of the community health centers. So that gets me to our program. So I oversee our program with Betsy Record, who's the Denver Health Refugee Services Coordinator. And then we currently have 3 NENS navigators, Adrian Matadi, Kwang U, and Rasulo. And Kwang and Adrian are based at Lowry, and then Rasulo's on the west side of Denver. And collectively, these 3 navigators speak Amharic, Arabic, French, Lingala, Swahili, Burmese, Karen, Po-Karen, and then also Somali and Mai. So next slide, please. So in July 2015, we initially hired NENS navigators. They were all themselves refugees. And this was originally done through a grant from the Colorado Department of Public Health and Environment. And in those first 3 years, we served about 2,000 NENS and refugee patients a year. And that was through about more than 12,000 patient outreach encounters. And during that time, the NENS navigators had a few different roles. One was connecting newly arrived patients that were being seen at the Denver Health Refugee Clinic to medical homes, and they were successful in connecting about 83% in the 3 years that we were evaluating that. And then they also provided navigation for other refugees and NENS patients who were already within our system. Next slide. Our program has also demonstrated, and these are before and after, improvements in cervical, breast, and colon cancer screening for NENS and refugee patients who worked with our navigators. This was also, we looked at this during the first 3 years of our project. But you can see the blue is the before and the red is the after. Next slide, please. And then this one is, as a pediatrician, this was a project that I wanted to just mention briefly, but after identifying a disparity in developmental screening at well child visits, there was a disparity for the non-English, non-Spanish population, whereas the English and Spanish population had good rates of developmental screening. We explored whether NENS navigation could help with improving this disparity. So during this project, we were able to improve developmental screening rates for non-English, non-Spanish children from 65% to 77%. And those rates have continued to increase since finishing the actual implementation project. For reference, the screening rate for English and Spanish speaking children is about 89%. We're still under that, but we're getting closer to it. Last I looked at our data. We also during that project found that non-English, non-Spanish children whose families were offered assistance from the NENS navigator had a much higher odds of completing the ages and stages developmental screening tool at about the adjusted odds ratio was 7.78. Next slide. So that's just a few examples of what our program was doing. And then COVID hit, and our program was about 5 years old when COVID hit. And as has happened for so many programs and health systems, our efforts shifted quickly to COVID outreach. So since the pandemic began, our 3 NENS navigators have outreached more than 5,000 NENS and refugee patients with information about COVID-19 prevention, masking, social distancing, all of those things. And then also with information about how to access our health system during the pandemic. This involved collaboration with our nurse line to make sure that our non-English, non-Spanish patients have a way to not have to go through our English-Spanish phone tree to access telehealth and advice, and also to schedule appointments. So that's been an important part. Just for reference, there's more than 10,000 NENS patients who receive care at Denver Health. The 10,000 is an underestimate because it reflects in-panel patients and patients who have an actual NENS language listed. And as I'm sure many people have experienced, we're still constantly working to improve our collection of demographic data. So next slide. So let's see, yes. So most recently, our efforts have shifted again to COVID-19 vaccine efforts. So prior to COVID-19 vaccine availability, our NINS navigators, we huddle weekly, and they were noting a lot of misinformation in their communities, especially on social media platforms. And as we talked about the expected vaccines and how that could potentially shift the work that we were doing in terms of our outreach, the navigators also expressed some personal vaccine hesitancy. So our first step was really to begin understanding and addressing the community concerns, and our navigators were a great place to start with that. So they collected a list of community member questions and concerns from the forums, the social media platforms that they were on, and then also from like other community members that they interact with, and from other people that they work with. And so they developed this list of concerns. And then my amazing colleague, Dr. Michelle Haas, who's with Denver Public Health, which is also tied to Denver Health, provided the NENS navigators with current vaccine development and safety information, and then very thoughtful answers to the list of questions that they had collected, and then also gave additional resources such as one of the blackdoctor.org webinars and the other Denver Health vaccine information sessions that Denver Health was doing for employees and community members. And then our team began also to openly discuss our personal vaccine experiences, just as a small 5-person team. So as a pediatrician in the emergency department, I was the first on our team to get the vaccine, and I was very open and transparent with our navigators about my experience, like the symptoms I had and, my decision process. And then and then over a short period of time, our whole team actually decided to be vaccinated. So we had this funny text stream going about everyone's symptoms. A few of us had joint pain and fever. No one had anything else really. But I mentioned this because it was a model for how the navigators began talking to patients they were outreaching. So next slide. Another thing I wanted to mention, the navigators were concerned. They were also noting early hesitancy about the Pfizer vaccine within multiple African immigrant and refugee communities, which was related to child deaths in a 1996 Pfizer meningitis treatment trial in Nigeria. And it luckily worked out well for us that the more trusted vaccine which was the Moderna vaccine, was at our community health centers, which are located closer to where the majority of our refugee and NENS patients live, and also it was also where their medical homes already were. The Pfizer vaccine was at main campus due to storage requirements, but it helped for the navigators to have that information and to be transparent, and also was reassuring to the navigators that they had information to give the patients about the locations of the vaccine, and that they could just be prepared in that way. Despite those early concerns, the navigators have really only had a few questions to date, and they were from Arabic and Vietnamese speaking patients who scheduled vaccine appointments. Next slide. So the navigators are currently outreaching more than 1,400 NENS and refugee Denver Health patients who are 65 and older. And this is part of our system-wide outreach efforts. We're collaborating with other efforts at Denver Health to outreach. One of the problems is that the easier way to schedule is through your MyChart account, and few of our NENS patients have MyChart accounts. So it's really important to be making those phone calls. Currently, just as of recently, about 34% of our in-panel Denver Health NENS patients over 65 have received the vaccine, and that's in comparison to 46% for English speaking and 51% for Spanish speaking. So, and the next slide. So we have observed that in some NENs and refugees communities, the majority desire the vaccine, and the issue is really about getting access. That would be our Arabic and Vietnamese speaking populations. Other communities have hesitant members who request more time to decide, but are frequently still schedule the appointment after a few conversations, but it does take a few conversations with our navigators, and the Ethiopian population is one where that has been the case. And then there's some communities with more hesitancy than others. So our Somali and Somali Bantu community and our Burmese ethnicities, there's more hesitancy and less uptake of the vaccine so far. But it's very important to note that even within the very hesitant communities, there's still individuals who want the vaccine and just need access. So it's important to be calling people. Next slide. So, and we are observing people are really wanting it in our NENs and refugee patients are wanting the vaccine at their medical homes specifically because of familiarity and transportation and many reasons. And it's been very important to have system and navigator flexibility related to being able to kind of switch to just offering COVID prevention and health system access when patients are hesitant about the vaccine, and then providing direct NENs navigator contact information so that that people can call back if they decide they want the vaccine. Deferring patients instead of removing them from outreach lists, because a lot of people just are saying, I just need more time. That it's taking a lot of conversations, and then close communications with our health system to ensure available appointments and support the equity efforts. So one of those has been blocking appointments that the NENs navigators can schedule into for NENs and refugee patients. Next slide. All right. Let's see. And I think, did I get through all these? Let's see. It's been really helpful for our NENs navigators to talk with patients about their personal experiences with the vaccine. And then I just included a few other observations that we've seen in our calls to patients. Next slide. So just a few points when developing culturally responsive navigation. So hiring navigators who are code switchers, who are comfortable in their own culture and community, and also very comfortable in the American medical health community, and being able to kind of work as a bridge between those two communities. It's been very important to have ongoing training and support, working closely with the navigators. We have weekly huddles. All of our work is very scripted, and there's standard work for the navigators that they are very closely involved in developing. And then we adjust that standard work based on their feedback. It's important to collect accurate language and birth country information in our health system. And then it's been very important to partner and communicate well with the broader clinic and health system efforts to ensure that we're supporting those and not duplicating them. Next slide. And then lots of people to thank, but most importantly, my NENs navigation team, Adrienne and Kwong and Rasulo and Betsy, and all of our many funders and supporters over the years. And I think that, and next slide. I just wanted to offer my email. Please feel free to reach out. I'm happy to share more about our processes and scripting and whatever is helpful. Next slide. So, and then these are a few more resources. So the first is a link to the Centers of Excellence. And the second is newly arrived refugee information from the CDC. And the third is a communication toolkit for non-English, non-Spanish languages. And then I will hand it over to Dr. Alfonso Rodriguez. Thanks.
Well, thank you very much, Christy. It's a pleasure to participate in this national forum. And I'm going to introduce the topic of farm workers and COVID-19 vaccination. I'm an epidemiologist with the CDC Division of Global Migration and Quarantine. But I would like to start with providing some background information about farm workers in the US that are relevant to attitudes and knowledge and access to vaccinations. First, there is an estimated 2.5 million hired agricultural workers in the US. Most of the farm workers in the US are born outside of the US, the majority from Mexico, but also there is an increasing number of indigenous or workers from indigenous communities in Latin America and Central America, and also for other countries. That is important because we know that indigenous communities tend to have more distrust of vaccinations than other populations. And also they have different language needs. They may not speak Spanish. Agricultural workers are considered essential critical infrastructure workers. Even though the data is limited so far, we know that they have experienced a disproportionate burden of COVID-19. This is mostly based on news reports from multiple outbreaks and multiple locations in the US. We also know, even though again the data is limited, that they tend to have low vaccination coverage. We don't have data so far about COVID-19. For example, a recent publication reported that only 14% of agricultural workers in the US have received the seasonal flu vaccine. So a very, very low vaccination coverage compared to other populations. Some of this proportionate burden and challenges in accessing vaccines have to do with the working and living conditions of farm workers and other negative social determinants of health that they experience, including high poverty levels. Most farm workers are limited English proficient and also have low literacy, including even in their own languages. Also, the majority of farm workers are non-US citizens with a high percentage of unauthorized immigrants, and that create barriers and distrust of government, and also limited access to public benefits. More than 50% of the farm workers don't have health insurance, and also even though they tend to be relatively young, they have a high prevalence of chronic diseases. It's important to mention also that the majority of the farm workers in the US are settled, meaning that they work close to where they live, and they have been living in the US for decades. But at the same time, there is a high percentage, about 30% of farm workers that are considered migrants, meaning that they have to travel to work, and those may experience likely additional barriers to access to vaccination during this pandemic. Even though there are multiple federal, state, and local agencies with responsibility on farm workers' health and well-being, and although there are many farm workers serving organizations, in my opinion, there is limited coordination and collaboration among all of those organizations, and also they have low capacity, relative to the tremendous need of this large and underserved population. So to help to address the needs of farm workers during this pandemic, including vaccination needs, the CDC has established a partnership with a national network of farm workers serving organizations. We are providing funding and also technical support to enhance coordination and outreach capacity of the organizations participating in this national network. So it's a pleasure for me to introduce Silvia Partida. She's the CEO of the National Center for Farm Worker Health, one of the largest farm worker serving organizations with a long history of serving these communities in the US. And she's leading the organization that is leading and coordinating this partnership with the CDC. So Silvia, please go ahead. She's going to talk about, provide more details about the partnership and some of the promising practices that we are implementing. Thank you very much.
Thank you so much, Alfonso. So as Alfonso mentioned, this project is a cooperative agreement with CDC funded just in October. It is the National Partnership for Preparedness and Rapid Response to Public Health Emergencies among agricultural workers. And I want to share with you some of the strategies and then talk a little bit about some tips that we are utilizing or sharing with you as you work with the farm worker community. Next slide, please. So this is, as Alfonso mentioned, there are many different organizations that serve the farm worker community, and they each bring a wealth of knowledge and experience, but many times those efforts are not coordinated or we're not learning from each other. So one of the primary and foundational strategies that we have, and which is illustrated here, is the development of a national network. And when I say network, I mean there's both formal and informal relationships of organizations that serve the farm worker community. National Center for Farm Worker Health is leading this partnership, is leading this network in very close partnership with CDC. And it's guided by a National Agricultural Worker Advisory Council. And this council is represented by various stakeholder groups. And we are also working with some core partners for the implementation of strategies, as well as with some strategic partners that will assist us in the broad implementation and dissemination of these strategies. Now, the core piece and what is extremely important in regards to this foundational strategy is that with our network partners, we're creating or hope to create a framework or a mechanism to develop and maintain the continuous flow of information to the farm worker community and from the farm worker community. And this is to help inform public health priorities, information, guidance, and strategies. Next slide, please. So I want to share with you some of our project strategies and then again go into a little bit of detail in regards to a few of those, especially around vaccination. So we are looking at data, and as Alfonso mentioned, sometimes there is a scarcity of data around the farm worker community, and that even makes this infrastructure that we are developing with these partner organizations even more important. So we are using this data to help guide the strategies, to stay abreast of the needs of the farm worker community. And we all know that with COVID, as with many other topics or priorities or issues that happen, this is an evolving crisis. And as soon as we think we have all the information, something changes. So the structure that we have developed with these partner organizations provides us with that information on a continuous flow so that we can rapidly look at do we need to pivot? What are some of the priority areas now? What are the needs that we are seeing? And also, as Alfonso has mentioned, that the farm worker community is diverse, and there are very different regional differences across the country. And so many times what works in Texas is not going to work in Florida. And so it's really important for us to really utilize the information that we are gathering from our partner organizations to help guide the strategies and the approaches that we're going to be taking. As I mentioned already, the foundational strategy is really at the core, and this is a very close collaboration with CDC. We are very fortunate to have a group of CDC advisors that help us with looking at health communications, looking at strategies, looking at health education materials, and providing that input on a very regular basis that then we share with the advisory council and with other members of this network. As you all have been talking about, and the need for educational materials is extremely high. And as we receive information from CDC, and we really need to look at it through the farm worker lens. So how is the guidance interpreted for the farm worker community? Is it taking into account the occupational and environmental risks, the housing situation, the mobility of the community? So in looking at how do we use the guidance that we are receiving from CDC and making it appropriate and effective for the farm worker community. We are also working with multiple organizations, and I liked what Nina said at the very beginning of this session, that this is a boots on the ground. And this is a great example of that. In our project, we are currently funding 6 different community-based organizations that provide outreach to the farm worker community. And we're planning to expand that to 30. So at this point in time, since we started in October and some outreach efforts started in November and late November, we have already reached over 50,000 farm workers and family members to provide education primarily around COVID. And now we're switching. We're going to be doing parallel outreach, both for COVID, because we know that many in the population, especially in the farm worker community, may not be first in line to get the vaccine, even though they are critical and essential workers. So we're continuing to do outreach on COVID prevention and safeguarding the community, as well as looking at opportunities to educate around vaccination. The education and training is not only for the farm worker community, but for those messengers. So who we're working with are community-based organizations, promotoras de salud, community health workers, but also employers. And so it's important for us as a project to look at the needs of not only the farm workers, but also those individuals that have the capacity and also the opportunity to be able to provide education and training. And then we're like many of the other projects that you heard about today, we're also looking at promising practices. There are many different organizations that have been able to implement an activity, been able to take guidance and really operationalize it. And so what we want to do is identify those promising practices. And they're at different levels. They're employer-based, community-based, and healthcare-based. And provide not only information about that promising practice, but really dig a little bit deeper into, are there standard operating procedures? Are there resources, education? Are there tools that can be used? What was the cost in order to implement that? And do you have any data, any quantitative or qualitative information that can be used to help us assess or to have others assess whether this is something that may be applicable to their community? And of course, a big strategy we have, a primary strategy, is to take all of this information, all of these resources that we're both developing and identifying, and have a way to disseminate it broadly to all our partners. Next slide, please. So I want to spend a little bit of time on the vaccination strategies and what we are doing right now. So in regards to vaccination strategies, we're looking at three primary areas. One is knowledge, then is vaccine confidence, and then access. So when we think about knowledge, we want to understand what is the information? How knowledgeable are farm worker communities on the vaccine? Do they understand it? Do they have questions about it? Is the information they have accurate? Is it valid? What was the source, or who is the source of that information? And is it current? And, we're all getting a lot of information about vaccine. And it's hard really to discern what's true, what's not true. Did I hear it from my neighbor? Did I hear it from my doctor? So really understanding what is the information that is needed by the community, and then providing information that will fill that gap, that will answer those questions. We want to ensure that people have the knowledge to make a wise and knowledgeable decision about their option for the vaccine. And then there will be strategies around vaccine confidence. So in the area of vaccine confidence, we're very interested in looking at the perceptions that farm workers have around safety of the vaccine. They may have fear of the side effects. I think earlier, Erin mentioned, if you're a worker and you don't have sick leave, and you may be reluctant to take the vaccine or have the vaccine because of the side effects, because that means a day or two, perhaps, of not being able to work. So really understanding what is the motivation, or what will be impacting their decision-making process. And also in general, we need to think about the mistrust that communities may have about the vaccine. And then a third level or a third area of a strategy that we will be working on is access. So we need to think about, for farm workers especially, but I'm sure it's for many other communities, is in general, we're looking at a community that is in a rural area, maybe in a place away from their primary home, and whether they will have access because of limitations in regards to their ability to call in for an appointment, their ability to navigate that system, their ability to have the equipment if it's an online process. So there are many issues with access that we need to decipher. We need to come up with some solutions and identify strategies that are going to increase access to the vaccine to these populations. And especially in regards to the work we're doing, is to look specifically around gaps around the country where farm workers live and work, and be able to provide some solutions to the communities in which they live, the health centers that may be available to them. And I think earlier somebody mentioned, and it's extremely important, is for us to think about how to deploy vaccine using mobile units. And it will be really critical in these very rural and remote areas of the country. So some key considerations. Again, I mentioned a little bit about the occupational factors. Alfonso mentioned that there are about 35%, sometimes more, of farm workers that migrate across the country. So here, it's not only about in what area of the country they will be in order to get a vaccine, but also if they're moving between vaccine 1 and vaccine 2. So again, those are some issues that we have to consider when we're thinking about farm workers that are migratory. I mentioned work hours and sick leave. Again, these could be barriers to accessing a vaccination. So again, looking at what are some things that we can do, that we can implement that will help with that. And then there are some just as the population, we know we've learned a lot about some of the risk factors that farm workers have around COVID-19. And some of those we can mitigate, some of those we cannot. So for example, when we think about farm workers in congregate housing, shared transportation, we know that they may be at a higher risk for infection because of that. Some of my colleagues have talked about the importance of language and culture and looking at some other social determinants for farm workers. Many have fear about public charge or deportation. We know that in some states, some providers of the vaccine are asking for verification of residency. So they're asking for a driver's license. Here in South Texas, we recently heard of a case where they asked for documentation of citizenship. So even though we're hearing messages about the vaccine is free, you do not have to be documented, you do not have to be a resident, those things are still happening. We're still having to deal with those types of challenges. And we need to be able to provide information to dispel those. Talked already about access. So I want to go on to the next slide, please. So lastly, I want to talk about, we've been working on and will continue to work on some promising practices. And again, I've talked a little bit about how we're organizing those. And it's not only for COVID mitigation strategies, but also for vaccination strategies. So just wanted to give you an example. If we were looking at a vaccination strategy that it's employer-based, we want to look at who are the primary partners? Is it an FQHC? Is it a local health department? Is it a mobile unit? What are the educational resources that are required, that are needed by both the employer and the worker? What are the languages that it needs to be in? What is the format? And who's the trusted source that is going to be providing that information? And how are we supporting that source? You know, what education needs do they have? And then we also need to look at, in a promising practice, is what are the implementation supports that they need? You know, do they need tablets to go out? What are the enabling services that are required, like interpretation services? Alfonso mentioned that there are many farm workers that speak indigenous languages, and we need to ensure that those organizations are equipped, if not with a person to do the interpretation, at least with a resource for that. And I want to mention, and I will put this in the chat, that many of the information resources, the promising practices, what we've learned will be available, and many of those are currently available at ncfh.org. I'll put it in the chat, and now I'm going to hand it over to Nina so that we can engage with the audience in some question and answers.
Thank you, Sylvia, and thank you to all of our speakers this afternoon. We're thrilled and delighted that you were able to share your afternoon with us. I know that I learned a lot, and I know that all of our audience learned and appreciates the knowledge and the expertise that you've shared. So we'd like to throw it open to some questions, and I would love to get us started while our audience is contemplating their questions. So I have a question that I'd like to ask to Bill and Erin. You mentioned that it takes a village to work collaboratively on RIM issues for vaccine, and you have a community leadership board. Do you feel that there are any professions that are actually missing from the conversation that should be part of this conversation?
So Aaron, I'll go ahead and take that one. And Aaron, please chip in if you think of any. You know, I think what we've learned, and you heard this throughout the whole forum, is the importance of community partners and the importance of community input and decision making. And I think we have a lot to learn about that. I don't think historically we've been very good at that. But there's also a lot of audiences, I think, that are kind of innovative and new that we hadn't thought of as sort of health audiences, and or trusted partners. And we literally learn about new ones, you know, on a weekly or bi-weekly basis. So one of our most recent ones was a attorney who really talked about the importance of attorneys, particularly immigration attorneys, and how they're seen as a very trusted source, particularly if they're from the community. And so we're consistently finding new partners who I think can act as trusted spokespeople outside of sort of our traditional, who we traditionally think of as health messengers. And then also other groups. The one I think that we've recognized that has been really overlooked is everybody talks about pharmacies and the importance of pharmacies during this. But we've noticed that it doesn't seem that anybody's engaged the pharmacies around what kind of health education materials do you need? What do you need in your pharmacy to get people in the door? And so we've engaged pharmacists and the professional national pharmacy organizations, and they've just been enthusiastic because nobody has seemed to reach out to them. We think of them as an end delivery, but they're actually interacting pretty much with patients in a sense. And so those are a couple of the newer ones that we've discovered. I'm sure we'll continue to discover more.
We were actually contacted by an immigration attorney a few days ago asking for resources, and we provided her with a response that contained your website and Sylvia's website but it occurs to me that maybe we offered to have a conversation with her, and we should invite you to that conversation.
It'd be great.
We're very interested, so thank you.
Right.
So I have a question now for Christy. What is your advice for programs and clinics interested in starting patient navigator programs? What are some of your lessons learned as you started?
That is a great question. So I shared a few of them. I think it's important to know kind of, first of all, to go to the community with what would be helpful and to really get suggestions from community members. I think it's also very important to plan your program keeping into account the location of the patients that you're serving in terms of where you plan to have your navigators and what population your navigators are from, what languages they speak. I think for me, the other parts, hiring is hugely important. Finding someone who can be both a trusted member in their community and also equally as comfortable working with the medical culture and the clinic culture and be able to be in both of those spaces well is a key to having patient navigators that I think a key to having effective patient navigators. And then I would say the huge one for me has been the team approach, that this is it's not like you just hire people from the community and that's going to solve your problem. You need to have it be something that's beneficial to the navigators and that you work all as a team. My team meets every week. At the very least, we're constantly texting each other and emailing each other and getting ongoing feedback from the navigators, because sometimes we plan something and it's not the right move or we missed a huge important thing, and having that open communication with the navigators is also very important. Community foundations are a great way to find funding to pilot a navigation program. At least in Colorado, that's been really successful for us, is local foundations who are interested in equity work. And it's just been an amazing partnership that way. So I'm happy to share more details with anyone who wants them to.
Thank you very much. So now I have a question for Sylvia. What, in your opinion, are the top 3 strategies that state and local immunization programs can implement to facilitate access to COVID-19 vaccination for farm workers?
Well, Lena, let me start. I want to start with one, and if I have time, I'll say 2 or 3. But really, the important thing is that farm workers many times are under the radar. You know, they come into a community, especially as Alfonso had mentioned. There are some that are migratory. We do have large numbers of farm workers that come in through the H-2A program. So you may have a community of 2,000 or 3,000 individuals in a very small rural area, and all of a sudden they have 10,000 farm workers there within their community working on farms. And so as a local and state health department, it's important to understand that the population surges that they will see, especially in rural areas and large and farm worker communities. And so being able to support those, not only support, but plan for those. So we've recently been approached by the state of New Jersey, and they're thinking way ahead. You know, they won't see farm workers, really large numbers of farm workers in their communities until June and July. But they're working with us right now to map out county by county how many farm workers and when the peaks will happen. And then they're doing focus groups with employers and community-based organizations to develop specific plans on what they're going to do when farm workers arrive in their area. So I think for me, that is one of the strategies that I would recommend for local and state health departments, especially in relation to meeting the needs of farm worker communities in their area.
If may I add quickly? I think to complement what Sylvia said, I think also that the opportunity of collaborating with employers. You know, vaccination is one of the areas where employers, farm employers, and owners are very open to provide access to their workers. So I think that's the great opportunity, and to collaborate with the farm worker serving organizations also in your counties and states. NCFH, the National Center for Farm Worker Health, and their website has created a directory of farm worker serving organization that you can use to identify, which of those organizations are in your geographic area. And finally, the third component, the third leg, is community health centers. They are the main source of access to healthcare for farm workers, and they receive specific funding from HRSA. And a number of vaccines we've heard have been reserved for migratory and seasonal farm workers at the community health centers. So that's another thing, great opportunity for collaboration by state and local immunization programs. Thanks.
Thank you very much, Alfonso and Sylvia. So going back to Bill and Aaron, I have another question. We have a little bit more time, unless something has come into the box.
No questions yet into the box that I haven't already responded to, but if you are listening and have questions for the presenters, please put your questions into the box and we can ask those.
Okay, so this one would be for Bill. After 25 years of educating health professionals about health disparities and working in refugee health, what observations do you have regarding health equity in COVID-19 vaccination?
Yeah, thanks, Nina. So I think we're at a really unique time, I think, in history. It's hard to pull back because I think we're all running and just trying to make it through the day. and I think it's hard to keep this moment in perspective. We're at a really unique time, after 25 years of trying to get, equity, and cultural humility and use of interpreters into mainstream medicine and public health and health systems. And I'm sure everybody on this call is familiar that it's been an uphill battle. And kind of this moment between having our larger public recognize and verbalize that there's systemic racism and that there is this inequity, and the timing and the colliding with the pandemic, I think has put us in a really unique spot. And, I've been really encouraged by a couple of things. One is I've known Alfonso for years, and I've known people who work in international adoption or with other groups. And one thing that happens in these RIM populations is they get divided up. And so I don't think I think so the people working with these populations work in their own pods. And I've been really encouraged at how all the communities have come together to work more collaboratively. And I think that gives these communities a much better voice, a bigger voice. So that's one thing. And then just this whole forum, I've watched a large part of the forum, and to see such a emphasis on health equity. The thing that I'm most concerned about is that when we get the pandemic under control, we go back to where we were before we started. And so my biggest hope is actually, I think we'll be judged in 5 or 10 years. Are we all still working together? Is there still a focus and a commitment to health equity? When it's diabetes and it's not going to be contagious to the general population, do we still care? And to me, that's how we'll be judged, and not just judged by history, but also judged by the communities. If the communities feel that we engaged them when there was a threat to everybody, but then we forgot about them, I think we'll be judged harshly. So my hope is we'll look back in 5 or 10 years that this was the start of changing the way health systems and public health work in the United States.
Thank you, Bill. Thank you very much.
I would like to maybe add quickly what Bill said in terms of this issue of health equity. I think at the same time, I think there is a gap, but we also have an opportunity. Right now, we don't have a national system to monitor health equity vaccination coverage among refugee, immigrants, and migrant populations in the US. And so I think that the opportunity that we have maybe at the state and local level, they can collect data that can help identify people from different national origins, different languages, refugee status, and to publish some of that information, because otherwise there is not going to be a way for us to find out if we have been successful in outreaching to these communities and ensuring that they are equitable access to the vaccine. So I think that's something I would like to highlight, because it's a gap, but also it's a great opportunity to do during this now during this pandemic, these vaccination campaigns.
Let's see, we have just a couple more minutes. I have another question for Christy. How have your patient navigators used social media platforms to communicate and outreach regarding misinformation about vaccine?
So another great question. So I would say, so they all, they aren't on the platforms as part of Denver Health, I would say. So they're personally on platforms and in community. And I'm not aware of all that they're on. So it's been more them, I think, just participating in the same way they're participating in their communities in person, or have prior to COVID participated in their communities in person at their churches and mosques, with being aware of what the concerns are in the community. So they haven't used it as a platform for communication with the community as much as it's just part of their daily life, and they're noticing what people are concerned about on those platforms. So I would say we have used social media we did, when we were doing our developmental screening project, they conducted interviews through Educa Radio. It was a collaboration in several different languages about developmental screening and its importance, and those were broadcast on Facebook as part of that project. So we've talked about, would there be ways to incorporate that outreach? We haven't done it formally through social media platforms. It's really been those one-on-one conversations, and sometimes 3 to 4 of those conversations with a patient that they're calling, that they've worked with often prior. So it's someone who's trusted calling and having a conversation. That's been the majority of our vaccine outreach.
Thank you. And then I have one final question for Sylvia. We can wrap up our forum. In some areas of the US, migrant and seasonal farm worker populations vary greatly throughout the year. How do you think that impacts access to vaccination among farm workers, and what strategies should be implemented to ensure vaccination for mobile farm workers?
Mm-hmm. And Nina, I touched on that in my previous response, but again, when we think about the distribution of the vaccine, many times we look at the resident population, and so understanding that population will increase as you see not only agricultural workers, but in other industries. There's also surges in the population because of the need for workers during a certain specific period of time. And so understanding that, and so it's really about knowing the population, knowing the industries and where you might see increases due to the occupations, the workers that are coming in for that. So again, I think that if we need to be able to secure enough vaccine and understand that some of the organizations that are going to be providing the vaccine to workers will need to have increases in the number of doses that they receive, and not rely just on the resident population.
Right. Great. Well,
Nina, before we wrap up, we had one more question in the chat for Christy. How did you address the Pfizer vaccine and the deaths to the children now that Pfizer COVID, I guess this is the example you mentioned about Nigeria. So how did you address that with Pfizer and the differences in the vaccine?
Yeah, so we interestingly haven't really had to address it that much because of having both vaccines, and the more trusted one, the Moderna, being closer to the community, like where the community members are receiving the vaccine. I've been actually really surprised. We thought we were going to have to address it and have a lot of scripting around it. And the navigators, their feedback has been, people aren't really asking about it when we call them, despite that it's on platforms in social media. So it's not something that we've actually had to have conversations about. Just the ones that we've had have been more a patient asking which one they're getting, and then scheduling and being okay with the location that they're being scheduled. So I wish I had more more to say there. I was expecting to have more to say based on the early information from our navigators, and I don't know if the community just knows both are available and they know that they can get the Moderna vaccine in the clinics, or if it's something else. So.
Thank you. Well, I'd like to thank all of our presenters this afternoon, as well as the organizers who invited us to do this session. And thank you to our audience for participating. The session, of course, is being recorded and will be available a later date for everyone who signed up for this session to view. And so we'll make sure it's readily accessible. And we thank you again and wish you all a good evening. Thank you very much.